Uh, I I am now. Okay, thank you.
It's Larry Fish. I'm here.
Oh, and Larry Fish. Thank you, Larry. So, just for those of you who aren't aware, and I think most of you are, we do record these meetings. We post them up on the website so you can re-listen later. And of course, there are a bunch of people who sometimes cannot make the meetings and who like to listen later on. So that's the reason why we do that. Oh, and I see Len's with us as well. I'm not sure how, but he's got Len's in and Len's out. Okay. So, Elaine, usually what we do is if somebody's never been with us before, we give them the floor if they'd like it, but only if they'd like it. Um, you can, if you feel up to it, you can tell us a little bit about your situation with your husband, and perhaps we can help you. I hope we can. Um, we we're a group of men and women, most of whom have significant experience with high risk recurrent or advanced prostate cancer. We've got people who are at all stages of the disease. By that I mean um, some who have recently been diagnosed with high risk disease and some who have been through most every treatment that's out there. So we have a huge amount of experience. And beyond the experience, we have a lot of tricks up our sleeve and questions that can be asked your medical team that may help you find an easier path than where you are. We do have a bunch of Canadians. I don't know if we've got anybody else from Canada on today, but we have several Canadians that do regularly call in. So if you don't feel comfortable talking about your husband's situation, that's fine, but at least tell us where you are in Canada and how you found it.
Well, yes, I'm from Toronto,
Okay.
and I found out about your group from another Canadian who we met through a support group in Toronto, and I guess she's been participating in your meetings. My husband was diagnosed originally in October of 2009. At that time, he had a Gleason score of 7, 4 plus 3, and he had radiation therapy in July of, he had a prostatectomy, I should say, in February 2010, and later on that year he also had radiation treatments. He didn't start on hormone therapy treatments until September of 2013. He started with Firmagon, and then he changed over to Zoladex. So he currently he's an interesting situation. The bone scans, CT scans, and MRIs he has not shown any metastases. However, he was recently diagnosed with what they call transitional cell carcinoma, which they thought initially was a radiation stricture in his left ureter due to the radiation treatments he had 7 years ago. The interesting thing is they went in and did a laparoscopic surgery, took out his left kidney and ureter, and the pathology did not show it as being transitional cell carcinoma, but actually metastasized prostate cancer, which was a huge surprise to the doctors because they say it's not normal for metastases to go to the renal area. So interesting enough, his PSA was up to 5.48 just after the surgery in July. He's into his 6th week of recovery, and as of last week has dropped to 3.9. So from a scan perspective, he's not considered to have any measurable disease. However, due to the surgery pathology, I guess he would be considered metastatic. So that's sort of in a nutshell, very, very quickly, some history.
And where's he being treated and by whom?
He's being treated at Princess Margaret Hospital by a Dr. Finelli. Have you heard of Dr. Finelli?
It rings a bell. I need to look. I can't do it right now, but I need to look in the database and see if someone else has mentioned his.
No.
We've certainly heard of Princess Margaret Hospital. That's for sure.
No.
Was it any chance Marguerite Florsham that you ran into?
Yes, it is. It was Marguerite, actually. I didn't personally meet her. She met friends of ours. We couldn't attend the last meeting because my husband was still recovering, but she sent a note, and it was due to her note that I was able to connect with you today.
Okay, yeah. We've known Marguerite for several years. She rarely comes on the call, but she corresponds frequently. I don't know. Len, are you on the call right now? Len?
No.
Len, are you?
Yes, Rick. Yes, Rick. I've been fiddling around with my wireless headset trying to get that to work instead of using the phone, but
That's okay.
I'm here.
You know who Marguerite Florsham is, don't you? Do you know?
Sorry, Rick.
Do you know?
Hear that?
You know Marguerite is, Len?
Oh, yeah, sure. Yeah.
Yeah. We joke. We had Elaine. We had a very, very dear friend of ours who passed away a little over a year ago, and Marguerite would call him up so often and ask him for and keep him on the line so long that I think Dominic's wife thought he had a girlfriend in Canada.
Oh. Well, I've not. As I say, I've not met her, but I certainly have heard about her personality through our friends. So right. I'm looking forward to meeting her.
So you can appreciate that, but she's very sweet and she's very nice, and I look forward to meeting her because she's coming out to the PCRI conference in LA early next month, and finally we'll get to meet her.
Yes.
So,
excuse me, a new caller online. Can you hear me?
Yeah, we can. Just hold tight, and we'll identify you in about five or 7 minutes. We've got a bunch of new callers. We're just talking with a new person right now.
I was just letting the group know I was on. I dialed an entirely different number, an access number, and it just played music the whole time. No people were actually talking.
Okay, well, now
I don't know if am I on the Reluctant Brotherhood call?
Yes, you are.
Okay. The number on the website seems inaccurate.
We'll
I had like 4 or 5 family members all on hold there for the last 7-8 minutes. Okay. And we're just now jumping off to come over here.
Okay, well, we will definitely talk to you with pleasure. Just give us a minute because we're right in the middle of speaking with someone right now. We'll be sure to come back to you right away, and we'll try and figure out what the problem is that you.
That needs to be charged, but even when I put.
So Elaine, let me just summarize then before I throw it open to the guys. So it appears that your husband had metastasis in one of the channels that leads out of the kidneys.
Yes, correct. And apparently that's extremely unusual. Nice. To the point that he's now considered a special case at Princess Margaret.
Interesting. And do we know if the cancer was adenocarcinoma or was it small cell or neuroendocrine or something they can't identify?
It wasn't endocrine. No, it wasn't. And the other good news was that the pathology did not show any spread.
Okay.
So it was pretty much contained.
Okay. And now how is your husband compromised by the most recent surgery?
Well, I mean, he's still recovering, but no real major side effects other than, he had quite a bit of pain.
Right.
The good news out of it is actually that his PSA has actually dropped.
Right.
Yeah.
And is he down to one kidney, or have they been able to sort of replumb him so that kidney?
No, they removed the kidney and the ureter down to the bladder, so he's now living with the one kidney. But they feel that probably he had severe hydrophenosis because of the stricture, and they initially were diagnosing it as the radiation stricture. So because of that stricture, his left kidney did have a hydrophenosis, and so they feel that probably he's been living pretty much on one kidney for a while now anyway, because it was compromised anyway.
Okay, and explain for the guys what hydrochronosis is.
I think because of any blockage in the ureter, I think your urine and any other liquids, back up into the kidney, right. And it's not able to drain properly, so it damages the kidney.
Okay. So we have a bunch of guys on this call that have been wrestling with strictures at various times, but nobody, I think, who's been dealing with strictures as deep as where your husband's was. When they biopsied the kidney, did they find any cancer in the kidney as well, or just in the tubes?
Just in the tube, thankfully, and the bladder was clear as well. Now they are going to, just to be absolutely sure, because the problem was it was originally diagnosed as this transitional cell carcinoma. And so they're just going to do another check on the bladder. He's going to have a cystogram and cystology done. But I asked the doctor, how did this happen? How is it diagnosed as another carcinoma? And then it turned out to be this. And he explained that, I guess, if you've been on treatment for any length of time, sometimes cancer cells start to morph and look like other tissue.
Yeah.
Have you heard of that?
It's becoming more and more identified and more common with prostate cancer, that as the disease responds to whatever treatment has been used, it changes, and what we generally see is that the disease starts to look more like small cell disease or neuroendocrine disease and behaves that way. Now, that obviously isn't the situation with your husband, but there are guys on this call right now, and they'll be speaking up, I'm sure, who are in that situation. And then we have to find treatments for them. I'll give you an example. I mean, we've known probably for 5 years that if you add carboplatin to docetaxel, it seems to address neuroendocrine disease.
And is that a chemo drug?
Yes, those are both chemo drugs.
Okay.
And now what we see more and more frequently, and Jim Harrington, who's on this call, is addressing it, and maybe other guys addressing it, that, excuse me a second, I'm just turning off my phone. Okay. There are other guys that are addressing it, that their disease, even though it's not exactly neuroendocrine disease, it looks like small cell disease. And I can send you afterwards. There was a very good article. I put it up on the. Are you on the phone to us, or are you on the?
Yes, I'm on the phone, Richard.
No point.
Or Rick. Rick, yeah. Sorry.
Either one is fine. There's no point in putting it in the chat window. But if you give me your email, or you can send it to me afterwards, I'll give you my email. There's a good article that was written about three months ago by 3 oncologists, genitourinary medical oncologists at UCSF, and they spend some time in that article addressing this issue. So
okay, that would be great. Yeah, I've got your email address from Marguerite, so I will send you mine, and then you can forward. That would be wonderful.
Yeah, we'll do that, and we'll also add you to the distribution so that you know ahead of time when we're meeting and all of that good stuff. Now,
Oh, that would be wonderful. Thank you.
the only question I really would like to ask you before I just throw it open to the guys, well, two things. The first thing is, Dr. Finelli, is he a genitourinary medical oncologist or is he a surgeon?
He's a urological oncologist. Yeah, he's apparently known quite worldwide for his robotic procedure, and he's the head of urology at the United Health Network, which Princess Margaret is part of.
What you need on your team, more than a urological oncologist, is a genitourinary medical oncologist.
I've not heard of that before.
Okay.
How do you spell that, please?
It's GENITO
Yep. Yep.
URINARY.
Okay.
And it's abbreviated just to GU, a GU medical oncologist. Let me explain for you and for any other new people on the call what that is. It is a medical oncologist, meaning somebody who's trained as a physician rather than a surgeon, who specializes in cancer and in particular specializes in the genitourinary cancers, which would include bladder, prostate, testicular, and kidney. And maybe a couple of others, I may have missed a couple, but those are the main ones. Now, those are the doctors that really understand how to treat advanced cancers in this region. There are a lot of surgeons who think they know how to do it and who claim they know how to do it, but to be honest, they're not the right doctor. And you can choose to go to a doctor like that. And you know, I'm thinking of what's the other guy who's in Toronto at I'm just losing his name and the name of the other well-known facility that's in Toronto. The guy's name begins with
Sunnybrook?
Yeah.
Sunnybrook?
Sunnybrook. He begins with
Yep.
a K. Lawrence Klotz, right?
Oh, yeah. Yeah. David went to Klotz initially.
Okay, so Klotz is another example. He's a surgeon, but he holds out as a genitourinary medical oncologist. One of the big problems in Canada is there aren't a lot of genitourinary medical oncologists.
Mm.
I know there are a couple in Vancouver. There's a guy with a Chinese name. I can't look for it right now, but I have him bookmarked. I know that Margarita's been looking forever and a day, and she really hasn't found anybody. But what you there's a guy in Ottawa too that we found recently.
Mm.
I'm sorry when I moderate on my own like this, I can't throw it off to somebody to keep talking. But if I can, or maybe I can, maybe Peter can step in a minute and help me out, and I can look for this. But having said that, it's really important, especially with such a weird cancer, that you really tie in to a network where there's a much broader depth. And for example, the hospital in Vancouver, I know it's an awful long way from me, but the hospital in Vancouver, they work with the American NCCN hospitals. The University of British Columbia does that, I know. So my biggest advice to you is to track down or start tracking down a GU med-onc. It's really, really important, especially with these weird cancers. Not to say that Finelli didn't do a great job with the surgery and the treatment to date, but I just think that, you're asking me about the cancer morphing and all of that. And this is really the field of the genitourinary medical oncologist. Let me throw it open to anybody who'd like to talk to Elaine about this. Anybody?
Hey, Rick.
Yes.
My name's Neil. I'm calling from Atlanta, and I got on the call late because of this the phone numbers that I was given. But did you happen to give out your phone number in the beginning of the call?
I did not know.
Are you able to share like an email or something with us in case we need to contact you?
Yeah, absolutely. We can do. I can do that, or you can always write to me, and then I'll get back to you through rd@ancan. That's A, N is in A is in Alpha, N is in Nancy, C is in Charlie, A is in Alpha, N is in Nancy. Okay.
.com?
.org. Sorry, Nick.
.org. So rd@ancan.org. Okay.
And we'll come to
Thank
you momentarily because we'll cover all the new guys, all the new people before we move on to the existing guys. Is there anyone else? Has anybody got any ideas or thoughts for Elaine in terms of a med-on?
Hey, Rick. Rick, this is Bill Franklin. Can you hear me?
Yes, go ahead.
Sometimes my mic doesn't work on this device. Yeah, I was looking on the web while you were talking. I don't know. I came in a little bit late. I don't know where in Canada she may be. But I found a website called Genitourinary Oncologist of Canada.
Mm-hmm.
Genitourinary Radiation Oncologist of Canada, and it's got a name of. It's got about 10 names here.
Okay. So it's called GU Oncologists of Canada?
The website is symptoma.com, and it has this listed underneath it. If you do a web search on Genitourinary Radiation Oncologist of Canada.
Okay. Okay.
Yeah, actually it's an acronym, GUROC.
GUROC. Okay.
And it came up. It's got like 10 names on here, so
Oh, excellent.
I don't know where you are in Canada. I'm sorry.
Toronto.
Okay. It doesn't give their locations. It just gives their names.
Yeah.
So.
Okay. Excellent. Thank you so much, Bill.
Maybe that'll help you from a start.
Elaine,
Yeah.
just bear with me 1 second. I'm just scrolling through my my list of people. I'm trying to find this guy that we found recently who he was quite impressive, and he was at University of Ottawa, and he was an Asian guy. I wonder if I put it under Ottawa. Well, if you send me an email, I'll do. Here it is, Michael Ong, O-N-G.
O-N-G. Okay.
Michael Ong, University of Ottawa, because that's within striking distance of you.
Yeah, that's about 5 hours. A 5-hour drive. 4 to 5 hour drive, depending on that. Yeah.
Oh, okay.
I'll look at the website that Bill mentioned, and I might find somebody else closer to the Toronto area.
Okay. And you can bounce the names off of us. It might be somebody that we've heard of. I mean, I know there's another guy, Neil Fleischner.
Yeah, Neil Fleischner. He works in the same team as Finelli.
Yeah, but again, he's a surgeon. He's not a a GU med-on. We got to get you to a GU med-on.
Yeah.
We can recommend you to some people in the States where you could go, but I know you really don't want to get into that. And this is the same issue that Marguerite's been wrestling with now for 3 years. So, fortunately, her husband's pretty stable, but she'd be a good person to talk to you. But send me the email, and we'll try and direct you to one of these guys. But that's what you want, and be careful when you go through these oncologists, because what you're looking for is a genitourinary medical oncologist. You're not looking for a radiation oncologist.
Right.
And you're not looking for a urologic oncologist, because those are the surgeons. Those are the cancer surgeons.
Ah, okay. Excellent.
Rick, this is Susan. One other thing to consider, this would be pretty straightforward, would be to ask the surgeon that you're working with for a recommendation, for a medical, medical oncologist specialist. They should know who the best people are.
That's true. That's true.
What we found, I'll come back to you in a second, Elaine. What we found in Canada is that when you go to Klotz, or you go to somebody like Finelli or Fleischner and you ask them for that, they say, no, we can handle that here. We have that knowledge. So they won't refer you through to a GU Medal.
Yeah, they tend to have egos a bit, don't they?
Yeah.
Yeah.
And so, that becomes an issue. Anyway, we're going to move on, but hopefully this has been helpful. You're right.
Oh, very much so. Thank you so much. And I will send you a note, Rick, so you have my email address.
Okay. So let me just identify the people that joined the call. I know that I'm a little confused about what the problem is. Jake, could you do me a favor and just check on the website, make sure that the telephone number and the code, the access code, is correct on the website?
The number that I was given today, I think he's the guy who runs the website, the s2.org, or 323-920-0091, and it gave the access code, but the music just kept playing. It was kind of like just kept playing. We never got connected, and then a family member who's also on the call somehow found the correct number, which is how I got on.
Yeah, no, that's not on. That 323 is not us. But I thank you for that, because I will make sure that us too has the right number for us. I'll make a note to send an email to us too to make sure that they have the right number. That's not our number. If you look at if you go to our website, which is ancan.org, A is in Alpha, N is in Nancy, C is in Charlie, A is in Alpha, N is in Nancy, ancan.org, and you look at joining instructions, or you look at support calls, you'll find our correct number and our correct access codes. But thanks for giving us the heads up that we need to reach out to us too. So Neil,
Sure.
You're on the call for yourself or for somebody else?
I'm on for myself, and I probably have 3 or 4 family members that are just listening, because we don't live in the same state, and it's just easier to all kind of participate. I don't know how long we'll stay on the call, but
okay, that's fine.
I was,
hold on, hold
go
on.
ahead.
Hold on 1 second. So I'm seeing 3 other callers on here that we don't have names for. If you are all Neil's family, you don't have to identify yourself. That's fine. But is there anybody other than Neil's family that has joined us in the last half an hour? Okay. So Neil, please go ahead.
Okay, so I'm 51. I do have family history. My father had prostate cancer, I believe at age 62, and he had the radiation seeds, and he lived a long life and died of something else, at age 87. The brother Steve, he's got some bladder issues, and he also had prostate cancer. So there's a family history. It had been 4 years since my last PSA, which was normal, and I just went to get a new PSA because I had some back pain for about 8 weeks, mild back pain that just wouldn't go away. And PSA was about 838. I went again 10 days later just to get a redo of the PSA, and it was 1,092.
Okay.
So I just got a bone scan, and the bone scan came back with, abnormal multi-areas. Seems like there's metastasis on every vertebrae, most of the ribs, pelvis, shoulders.
Right.
And, I saw the images. It's all pretty lit up,
Right.
And so I'm going for the biopsy tomorrow, which seems like it's almost a moot point to go get it, but I guess they want to check the box to make sure, I guess. I don't know what else it could be. But so my question is, and I'm going to help.
Okay.
Go ahead.
There's a lot of good reasons to get a biopsy. We don't have We don't have Dr. Steve on the call tonight, but Dr. Steve got diagnosed about.
Actually, I'm here, Rick. Rick, I am here.
Oh, you are here.
I am. Yeah.
Steve, you wanna tell this gentleman why it's a good idea to get a biopsy?
Yeah, sure. I'm 2 years ago, I was in a very similar scenario to yours. My PSA was about 1,000 and multiple bone metastases, but I'm a physician. I'm an obstetrician gynecologist and informaticist, and I made a decision on my own not to have a prostate biopsy because the diagnosis it seemed to me clinically pretty apparent. And that 2 years down the pike has given me some issues around being able to participate in certain clinical trials that I really would like to participate in. So I would encourage you to go ahead, even though it's rather obvious that you do have prostate cancer and you have a high grade of Gleason score. I would encourage you to do it. It's not a terribly painful procedure. I did ultimately have it done later on, but it was negative after some treatments. So I would absolutely agree with Rick. I would have it done. It's not just to check the boxes.
Hey, Steve, let me ask you something about these biopsies, because the guy who I went to see said, because I know they usually take like 12 samples or so. He said, yeah, because I probably won't take that many samples on you.
Mm-hmm.
Is that wrong, or should he take the standard amount?
I think it depends on how apparent it is. I assume these are sonographic biopsies. He's not going to use an MRA or a fusion type of biopsy. If he's a sort of your average urologist that's doing this, more than likely with that PSA, even if you did one biopsy, it's going to be diagnostic. You're going to have cancer there. You don't really need to, with extensive out of the prostate metastases like that, I don't think you really need to, have 12 biopsies. I think if he's confident on sonographic that he's gotten at least 1 or 2 cores, I would go with that.
So he might just go 1 or 2 areas and that's it?
If he's confident that he's gotten areas of cancer, just to make a tissue diagnosis, you have prostate cancer. There's absolutely no question of that. So, and you obviously have aggressive prostate cancer. The only reason you're having this done is later on, well, 2 reasons. One, so that you might be eligible for certain clinical trials that do require a histologic or tissue diagnosis. And the other one is, and Rick will talk about this, I'm sure, is to go ahead and have that tissue sent for genetic analysis and see exactly what mutations exist, also in the hopes of looking for some specific, so-called personalized care, something that might apply to the specific mutations that you carry. So those are the 2 reasons to really have it done.
So let me ask you this. When they send the biopsy out, do they automatically test for mutations, or do you have to request it?
No, they don't automatically at all.
No, you have to request it. But Neil, I just want to tell you an interesting story with Steve. Steve plunged right into chemotherapy, which was clearly the right thing to do. And what was it, 9 months later, when they went in to try and biopsy your prostate to see if they could get a sample, they couldn't find any cancer in there. Isn't that right, Steve?
Well, I also had stereotactic radiation by that time as well. So a couple of good reasons why they didn't find prostate cancer in me. And I did actually have genetic testing using this probably a little more complicated than we need for this discussion, but a so-called liquid biopsy using Foundation One's ACT test, and it did discover a couple mutations. But the clinical trials do not, at this point, which is a little backward, but they do not consider that to be a tissue diagnosis. And so the bottom line is just have the damn biopsies done and don't worry about it. It's no big deal compared to what you're going to be going through.
Well, I'm not too worried about it. I just want to make sure if I do it, I'm sending it off to get it tested in the right way. Like to your point with this, the tissue diagnostics on it, the mutations, the biomarkers, all that. Is that something that's standard, or is it a different lab that they have to send it to?
We'll walk you through that, but let's just get a little bit more of your history.
Okay.
Where are you? You said you're in Atlanta, is that right?
I'm in Atlanta. Yeah, I'm trying to get a referral outside of Kaiser to go to Emory because it's the only comprehensive cancer center in the state, so I'm told. But but they're pushing back on giving these referrals. So to your point, I don't want just the average oncologist. I want someone who's sort of an expert if such a thing exists.
Right. Well, you also happen to have hit the gold streak here, because we may be able to give you some ideas on how to do that too. But let me first say that in Northern California, we have put a lot of pressure on Kaiser, and eventually they hired a really top class genitourinary medical oncologist. Now, my guess is, and you may know, we could check, but my guess is that Georgia doesn't have a good GU med-onc within the Kaiser system. I'm going to go back to Dr. Steve and ask him what he might suggest, because he has a little bit of experience with Kaiser.
Well, I've got a little more than a little experience. I worked for Kaiser as a physician for 32 years in Northern California. And I know Georgia, Atlanta's Kaiser set up pretty well, because I actually went back there and spent a few weeks years ago setting up their electronic medical record systems, helping them out with that. You're not going to get a referral to have all of your care at Emory. I can tell you that as well right now, because, but you can certainly convince them to have a second opinion by a GU med-onc at Emory, or you could even just do a virtual opinion to the woman that Rick is talking about, Andrea Harstark at Oakland Kaiser, who is extremely good. I have seen her, and she works with me, and they'd be happy to set up a virtual consult wherein basically, through what's called kp.org, you're probably familiar with that, you just make a virtual appointment, and your whole family can participate. And I think that would work every bit as well, because they'll have all your medical records right there in front of them, even though they're in Northern California and you're in Georgia. So that's what I would encourage. They're not gonna give you a referral to have your care at Emory. I can tell you that flat out. I
was hoping at least I could go to Emory, get the plan, and then bring it back to Kaiser and say, this is what I want.
Right.
Yeah,
you can do that, but it's going to be out of pocket. That referral, and it's certainly not unfeasible. But I think before you do that, I would explore the possibility of having a virtual consultation with Northern California's GU med-onc, the leader for the Northern California area.
Neil,
and her name is Andrea Harstark.
What is her name? Can you spell her name out for me?
We will. Let me
put it on the chat.
Let me just follow up on that. Neil, you're on the phone, right? You're not in the chat window, correct? You're not online.
I'm on the phone, correct.
We'll spell it for you. But let me just follow up with that. I think you'd be hard pushed to find a GU med-onc who is as talented and as good as Andrea at Emory.
I'm sorry, can you say that one more time? You say I won't find one as good?
I don't think you'll find anybody as good as Andrea at Emory. I mean, if you told me you were going to, you wanted to go to Duke, or you wanted to go to MD Anderson or what have you, I might say to you, you know what? There are some really good people there. But, we were talking before, and you probably heard about about docetaxel and carboplatin. And Andrea was the second author on that paper when she was at UCSF. So she is not only is she a great person, because we know her personally. I've known her for 5 or 6 years now, and Steve knows her as one of his doctors. But she's really bright, and I think that if you wanted somebody within the Kaiser system to guide you, that you're not going to do any better than. I mean, I don't know the ability from Georgia Kaiser to get a consult with Northern California Kaiser, but if Steve is telling you that can be done, it can be done. Whatever you do.
That's great news. Thank you so much. I hope I can get phone numbers before we all hang up, like of Steve and Andrea.
Yeah, we'll help you. We'll take care of you. So first
great, that's good news.
Andrea Harstark. It's Andrea, Andrea. Last name is Harstark, Harztark.
I'm sorry. Can you start over H?
Some controversy, and you're alone.
There's a lot of people. There's some chatter, and I can't hear.
You there?
Right, I think it might be.
If anyone's on the call, can you put the mute button, because I hear people chit chatting and I can't hear Rick.
Uretary oncology.
It's Elaine. It's Elaine that's chatting there.
I'm
Elaine.
sorry. I thought I had it on mute. How do I get it on mute?
I'll mute you, Elaine. I'll mute you now, and I'll unmute you in a minute.
Okay, thank you. Sorry.
Okay.
All right, so I have Andrea's first name, but not the last name.
So the last name is H as in Harry, Alpha, A as in Alpha, R as in Richard, Z as in Zebra, S as in Sugar, T as in Tommy, A as in Alpha, R as in Richard, K as in Kitchen.
So H-A-R-Z like zebra, S-T like Tom, A-R-K?
Yeah. And
wonderful.
And she's at the main Oakland Kaiser. What's that Kaiser branch called, Steve?
It's just Oakland Medical Center.
Oakland Medical Center in Kaiser.
You can go to kp.org, Neil, and look her up. Just go to kp.org and put her name in, and then bring up her web page, and you can get her background and so on.
Right.
And she's a GU medical oncologist?
Yes.
That's correct. She actually is in charge of Kaiser Northern California's program for GU Med-Onc. So there are other GU Med-Oncs, like I go to one in South San Francisco, but she oversees the entire Northern Cal program, which is quite big, compared to Georgia. Georgia would be the equivalent of one small clinic, and there's 30-something, outpatient units and 15 hospitals in Northern California. So it would be Georgia expanded to 30 times the size, so to speak.
Right. Well, that's really good news, because it sounds like she's exactly what I need.
You can tell her, or you can tell through your doctor, tell her you're referred by Rick Davis and by Steve Bornstein.
Rick Davis and Steve, what's his last name, Steve?
B-O-R.
Go ahead, Rick.
S-T-E-I-N. B-O-R-N as in Nancy. S-T-E-I-N.
Bornstein.
Right.
Yeah.
B-O-R-N-S-T-E-I-N.
Right.
Right.
The next thing is that, see how you do. You've got 6 months to try this system out. And if at the end of the 6 months or the 5 months you don't like it, then you've got the opportunity to switch your insurance at the end of the year.
Well, Rick, he's 51, so be careful there with the Obamacare stuff going on. And I don't know what kind of insurance you have, but you want to be real cautious about switching insurance. Do you have it through work?
No, it's just through the exchange.
Yeah, you want to be a little careful.
Okay. I had thought.
There's an echo. Someone's got their phone on speaker. Can you turn it off?
I had thought that pre-existing conditions were no longer an issue, Steve.
I didn't hear what you said, Rick. I'm sorry.
No, the pre-existing conditions are at this point not an issue, but with the Trumpsky there, God knows what's going to happen, Right. But the only other thing is these exchanges are going to get increasingly expensive, and if you're in the Kaiser system now, that's a solid system, and I'm not saying this just as I spent my career at Kaiser, but I would be a little leery about exchanging that for something else at this point, because healthcare in the United States, it's tenuous right now.
Well, it is, but it's a challenge to get state-of-the-art treatment through Kaiser. So let's talk a little bit about this genetic testing. Steve and I have actually been working with the providers of one of these tests to see if we can't figure out a way that we can make genetic testing available to the Kaiser population. But it's very difficult, and they're slow, and it's sort of, I wouldn't say it's fallen by the wayside, but it hasn't been a priority. For you right now to get sequenced, you probably are going to have to do it privately, and we can help you do that, and we can also help you get subsidized to do that. but I don't think that you're going to have much luck getting gene sequenced through the Kaiser system. But Steve, would you agree or disagree? Or how, if you were a Kaiser person, how would you get sequencing done?
Well, it's changing rapidly. In talking to some of my friends, they're actually opening up a genetics lab down at Kaiser that is using sequencing for all systems. We're getting an echo here.
If someone has their speakerphone on.
Yes.
Yeah.
We're getting.
If you're not talking, put your phone on mute.
Let's see if that helps. Yeah. Okay, that helped. Yeah. So it's complicated and changing, but I think what we're talking about now, Neil, this is a big pill to swallow all at once here. I think the first thing you should do is just get the biopsies done. Start on ADT if you already haven't done that with some Lupron or whatever they're going to recommend. And then there's no rush to have the gene sequencing done, because once you have the tissue, you can just use one of those slides, and there's a host of different places where you can get that done. The one that Rick is and I have talked to is Foundation One in Cambridge, Mass, which is fine. I can tell you Kaiser is not going to have one, and they're going to probably tell you it's not standard of care and you're going to have to pay for it out of pocket. But as I discovered, because the drug companies so heavily subsidize this stuff, Foundation One is going to waive any fees. So all you got to do is get your oncologist to order it and send the slide, and they'll bill Kaiser, and they will reject the bill, and then after that, nothing will happen.
Okay.
So that's kind of how you do backdoor-wise. But we can help you with that as you go through this. The first thing is just get the biopsies done.
Okay. I've heard some, I've been often wondering, should I have my testicles removed? Should I get the prostate removed? Even though it's spread, is that something to do that's a good thing or not?
Steve, you want to feel that?
Yeah, I'm sure. No, you definitely don't want your testicles removed. The LHRH agonists and antagonists are equally effective. It's just a shot every 3 months or every month, depending on what you do. It'll put you into it'll drop your testosterone essentially to 0. You don't want your testicles removed for sure. That's unnecessary, and I wouldn't even think about that. What was your other question, Neil?
Getting the prostate removed, since that's the source of the cancer.
Right. No, that's not, it's sort of the horses out of the barn kind of situation. And radical prostatectomy is got a lot of complications, and you don't want that. At the most, if you're going to aggressively treat it, you could have radiation to the prostate and to the surrounding bed, which has much fewer complications, especially if it's stereotactic, so-called cyberknife, variant of that. But you don't want a radical prostatectomy at this point. The horse is out of the barn. It's not going to help you, and it has all kinds of potential complications.
Right.
They won't even do it. They won't do it.
Is there anything I should do in terms of like the next step? Should I get a soft tissue scan, like a CT scan with contrast, or what's the next thing to see if it's spread to soft tissue, or does it not matter? Or is that something they should know?
Well, they should do a CT scan as a matter of course. They should have done a CT scan and a bone scan. Certainly that's what happens in Northern and Southern California. So if they haven't done a scan, you could certainly request one.
I just had a EB CT scan, but I don't know if that's the same technology as just a regular CT scan. And anyway, Kaiser won't read it because they didn't get it done at Kaiser.
Well, I would ask your urologist.
I'm sorry, what kind of CT, Neil? Did you say?
Electron beam CT scan.
Electron beam. You mean a PET CT?
Is that what I need? A PET CT?
I think you probably need a PET CT. That's absurd. Of course, Kaiser can read it. If it was done, by a legitimate physician and not like a chiropractor or something.
No.
They
won't read it, but.
It has to be abdomen and pelvis. So what area of the body was it done?
Yeah, they got the heart, lungs, abdomen, pelvis.
Yeah.
They got all that. In fact, they said it was like the prostate had grown 4 centimeters from the 4 years ago when I had it done last. But I don't know if it looks at soft tissue, because mostly it was the calcium scoring of the heart is sort of, but I don't know if it looks at the other kinds of diagnostic abilities, you know, that these other techniques have, like PET and CT and like CT with contrast. I don't really know all the modalities, but.
Well, you need a CT. I mean, the CT is not a big deal. I mean, along with the technetium bone scan you had, which did light up, so you have bony metastases, which is, you know, the sort of the classic presentation of metastatic prostate cancer. You have to see if you have liver metastases or soft tissue metastases, chest metastases. So you have to have a chest and abdomen and pelvis CT. And what you had probably wasn't looking for that. So it's no big deal to have that done. I would just have them do it, because it will change your treatment if you have soft tissue metastases.
Right. And like I said, I think I have it, but who would I even call? The radiologist who read the EBCT scan, and ask him, does it look at,
I think
just get?
the thing is, why not just ask Kaiser to do the CT scan again?
Well, because it could be another $1,500 or $2,000.
Oh, you have a big copay. Yeah.
Yeah, but I mean, I guess I'm going to be spending that money anyway. It's just, yeah, it just seems kind of silly if I just had it done like a month ago.
Well,
and I have the disc, but they told me they won't read it if it wasn't done at Kaiser. Somebody told me that, and they could have gotten it wrong, but.
Yeah, that doesn't sound quite right. I mean, Georgia's, I mean, having spent 2 weeks there, and this is no offense to the South, but, you know, it's pretty backwoods, I have to say, for a Kaiser facility, but there's no reason why I can't have a radiologist read that at Kaiser. That's crazy to have it done again at a $1,500 expense. And if you've got the disc, they should be able to take a look at it for you.
And is there anything special within the CT category? Is it CT with PET, CT with contrast, or is it just a regular old straight out of the box CT scan?
well, I think for you, given where your disease is, probably a regular old CT scan is going to be definitive enough to identify if you have metastasis in any of your organs, which is what they're looking for. It's not like we're looking for lymph nodes where it's a lot finer. The level, the degree of accuracy has to be very, very fine. I mean, you're
just looking for a baseline to see if it's going to, you know, the next time you're staged with a CT, you want to be able to see if it's, you know, better or worse. So this is your baseline.
I mean, on the CT scan I had, they said, you know, lungs look good, liver looked fine. I mean, so it just seems odd. I guess I can schedule an appointment with a Kaiser radiologist, but I don't think they really see people, do they?
No, you can't do that. You just only can request that they read this scan for you. And I don't quite understand why they wouldn't do that, except if it's a copay situation and they don't want to engender you with a second copay to have a second reading done. But, you know, having a CT, if you've already had it done and it's going to cost you $1,500, that's a good reason not to have it done again, as well as the radiation. CTs, there's a lot of radiation exposure as well.
There's a lot or not a lot?
There is a lot. I mean, people like us don't have to worry about it as much as somebody like Rick who's going to live to 100, but still.
But let me sort of sum up here, because we're going to have to move on. We've got a lot of people on the call and we've got to get around them. The first thing I want to tell you is that if you get on the stick and you start getting treatment, that this disease can be managed, and you're hearing that speaking to Steve, whose PSA has gone down to as low as 8.
But what about the bone cancer? Does that go away, or does it just always stay where it is? It's worse, you know.
The bone cancer can be managed and it may be reduced, but like I say, Neil, I can't. Unfortunately, it's not fair to spend more time with you at this point because we've got a lot of other guys on the call.
No, absolutely, and I appreciate everything. It's been very informative, and I thank you. And I'll email you and try to get maybe Steve's phone number, or unless you want to give it to me now.
Yeah, I can give it to you, or however you want to do that. Do you have I can text it to you. You have a cell phone?
Yep.
Okay. Well, so let me just give you my cell phone, and we can text or chat if you like.
Okay.
So it's area 650
right.
554 0503.
I'm sorry, 650-54.
554
Okay.
0503.
Okay.
And I'm happy to talk to you further. I think the first thing, though, Neil, is just go ahead and have the biopsy done, get started on treatment. If necessary, get the CT, and then things will fall into place. I mean, as far as, how you treat the bone mets, et cetera, et cetera. These are things, you don't have to decide these things today. I mean, these are things that sort of make themselves obvious over the next few years.
The one thing,
Okay. Well, hey, thank you very much.
the one thing, Neil, that really is important, given you have extensive bone mets, and then sadly, this is not always the protocol, so you must insist on this, is that if they are going to give you a hormone therapy shot, which is normally called an LHRH shot, and the drug that they use mostly in Kaiser is a drug called Lupron.
Right.
To be absolutely sure they give you 10 days or 2 weeks of bicalutamide or Casodex first.
That's what I'm taking now, actually, for the last 3 days.
Great.
Yeah.
Okay.
There you go.
Excellent.
50 milligrams 3 times a day.
Okay. So as long as you're getting that first, then they're teeing you up to give you an LHRH shot. And that's the first thing that you've got to get into you once you've built up some resistance from this drug that you're taking right now. Okay?
Okay, great.
Now, you have my email. If you email me, I'll send you back my details and we'll guide you some more. But, there's a lot of stuff that you've gotten out of this to keep you on the right track.
Sure. Well, thank you very much, everyone.
Okay. All right. I'm sorry, guys, that we didn't open that up, but it just, there was a lot to pass on, and we just don't have the time. So let me first of all check, is there anybody who has joined the call in the last half an hour that hasn't identified themselves yet? Or would like to identify themselves, who hasn't announced themselves? Okay. So let me quickly run down the list of people that I know are on the call, and we've got just about an hour, and hopefully we can get around a bunch of people. So let me start with Jay Kruckman. Jay, is there anything you'd like to speak about tonight? How you doing in that search to find a doc?
Well, I got my new PSA results back recently. I have an appointment with my local urologist here on Wednesday, so we can cover that later.
Okay, so we'll touch base with you quickly. We'll probably start with you. We'll touch base with you, and we'll talk to you. Steve, is there anything you would like to? Dr. Steve, is there anything you'd like to talk about tonight?
No, I've already talked plenty. Thank you.
Okay, thank you for talking plenty. John Appler, anything for you? John Appler? Okay.
Rick, I'm sorry. Yeah, I'm fine. Thanks very much for asking.
Okay, good. Paul Frieda, anything for you tonight?
No, nothing for me tonight. Thank you.
Okay. So everybody can unmute until I finish the round robin. So if you think you've muted yourself, you can unmute now. Howard Hertz, anything for you tonight?
No, thanks.
Okay. Dennis Correa, anything for you tonight?
Yeah, I got my genetic inherited test back.
We'll come back to you. Susan, would you like to talk to us tonight?
Yeah, for a little bit.
Okay. Mike Tamales, would you like to talk to us tonight?
Yes, I would.
Okay. Eric Bookbinder, anything for you tonight? Eric? Are you muted? Unmuted? All right.
There we go. Can you hear me now? Yeah, no.
No?
I got so much that probably don't want to do it tonight.
All right. Well, let's see if we can try and make some time for you. At least we can sort of start digging into some stuff.
Okay.
Sylvester, anything for you tonight?
No, not tonight. Thanks very much.
Okay. Peter Kafka, anything for you? Peter? Peter, are you with us? Okay. I see him with us, but he must have stepped away, so I'll check in with him again in a minute. Larry Fish? Oh, there's Peter.
No, I'm okay tonight, thanks.
Okay. Peter, anything for you tonight? You're muted. Peter, you're muted. Well, I'm not certain why, but we can't hear you. We see you, but we can't hear you. Okay, nothing. Len, Sierra, anything for you?
Oh, thanks, Rick.
Okay. Have I missed anybody?
Jim Harrington, Rick, I have nothing tonight.
Sorry, of course. Jim, for you.
Yeah, what?
You'd like to talk, I'm sure.
Are you sure? All right. Okay. Okay.
Yeah, you can just tell us how you're managing through this first cycle of chemo. All right.
Okay.
Let's
Get Jake, but I don't have anything either.
Oh, sorry, Jake. Anything for you?
No.
Okay, I beg your pardon, Jake.
No problem.
Okay, so we're going to move pretty quickly tonight. We're not going to be able to delve too much, but we've got some people that really do need to talk. I'm aware of that from some background. So let's try and get around as many of you as we can. Jay Kruckman, how did your PSA come back, and how are you doing in this search to find a doc?
My PSA came back at a 0.20, which my last one 3 months ago was a 0.06, and 3 months before that was a 0.01. So depending how you look at it, I've gone up 20-fold in 6 months, or I little over tripled in the last 3 months.
Right.
I have an appointment Wednesday with my local urologist to discuss the results and go from there.
Okay. And this is your urologist in Memphis, correct?
Correct. Yes.
I think that if it were me, when I had that appointment, I would be telling him that, you're really looking for a GU med-onc, and see if he's got any suggestions that he can send you to.
Okay.
I think that probably you need to lay out your stand, lay out your stool, and let it be known to him, Jay, that at this point, what you really want is to be working with a medical oncologist rather than a surgeon. And he may have some ideas as to people. My guess is that there's got to be somebody else at Vanderbilt, even though I know that Alicia Mason, or I forget her last name, is not there anymore. The chances are that somebody has taken her place. And, he's likely to know. At the same time, I recall that when you called over there, they didn't, Alicia Morgan, that's who it was. When you called over to Alicia Morgan, they didn't have anybody that was kind of filling in for her. Is that right?
They said they had people in place, but it was different. Now,
hello.
I do have the opportunity. Are you there?
Hello?
You there, Rick? Everybody else?
Can you hear me, guys?
Yeah, I can hear you fine.
Rick,
I
I
hear
can
both
hear
of you.
Now, Alicia Morgan has gone up, I believe, to Chicago. I believe it's with Northwestern, and I do have the opportunity to probably be up there in the next 2 months, do a family wedding.
Hello?
Because I'm from that area.
Can you hear me?
So I will keep talking, and Rick can catch up maybe. So I will try and catch up with her. But she will not be available till September 1st. So I will be looking at that option.
So I don't know if people can hear me or not, but I have gotten lost here.
We can hear you, Rick.
Hello?
We can hear you.
We can hear you. And we can
Rick?
also hear Jay.
I guess my question to the rest of you, besides Rick, who can't hear me, I guess, is looking at the Stampede and the charter trials and everything else, is where do you look at starting things along with ADT therapy? The chemo or Everotone or whatever, and that's where I'm kind of questioning things.
That's where you need a GU med-onc on your team to help guide you on this. This is not a personal decision you're going to make. I mean, you need someone who's really on top of this stuff to just decide how aggressively he wants to treat you.
I'm sorry, somehow I got muted there.
I think Rick is meeting various people right now.
Looks like Rick muted all of us.
Yeah. I don't think he can hear us.
I don't hear him anymore.
Did Mike